Good afternoon, everybody. It's about 1:30. Hope everybody had a good lunch. We're going to stream one more presentation this afternoon. Then I'm going to start uploading some newer content that we recorded even just this morning and then last week for the kind of wrap up the afternoon for today. And then there'll be a few things that will be on there for tomorrow. I'm trying to do this so like by weeks. Last week obviously was messed up because of the weather on Thursday. We did do some live streaming that day. We'll need to make up some of those skills. Right now I'm looking at the 28th of February. That's 2 weeks from tomorrow on that Thursday in order to make up some of the skills that are part of this. Remember your reading assignments. I'm going to say that again. If you'll give us just kind of a hello on the YouTube channel to let me know you're here, that'd be great. Don't necessarily need to use the sign in, sign out button on the web page itself until we're done with the day. So whatever today's assignments are, when you're kind of done with all that stuff, sign out. So I'll send out a text later on saying if you got everything done, it's a great time to sign out. So that'll give us a good record keeping of each day, kind of who's participating, who's not. So when we need to show proof and record stuff to Bureau of EMS and such, we'll have something to show them. This presentation is going to be Aaron, and Aaron's going to talk about 12 leads. So this, for the basics out there in the world watching this may be, just pay attention. It's still good information, and it fits nicely into the cardiology section for some review. I've also got a quiz for you, a little review quiz, 8 questions, so pay attention to this. It'll be some stuff that was covered earlier. So, all right, Aaron, all yours.
Howdy, guys. Like I said, we're just going to go over some 12 lead. It's kind of more of a STEMI recognition. Trying to be able to recognize where that injury or what the different injury patterns are for different STEMIs and things like that. We're going to kind of go back and review, especially this will be good for some of the EMTs in the room. There's going to be a little bit of review here for your paramedics. EMTs, there's going to be some stuff on here that, kind of maybe explain a little bit. Like I said, some of you guys may know, some of you may not. Explain a little bit about what you're actually looking at when you're looking at an ECG. So some of the stuff, like I said, we're going to go over is just like what the waveforms are, the intervals, what normal is supposed to look like, what actually is myocardial ischemia, injury, and infarction. So, and then the things we'll actually see on the 12 lead when we're seeing that in different parts. Identify 5 major infarct errors on the 12 lead. We're going to get into a little bit like when we shouldn't do like a 15 lead EKG. We'll name some of the occluded arteries common to the area, determine the ECG changes reflecting ischemia, injury, and infarction, and then some of the cardiac enzymes that we're looking for. So what is an MI? So myocardial infarction is a result of the occlusion of arterial flow to the myocardium. Okay, so blood flow is not getting to an area of the heart tissue. Ischemia. Ischemia, injury, and necrosis is going to result as of this. Okay, so those cells are going to start dying as soon as they don't get oxygen, things like that. Remember, this is a time-critical deal, just like stroke or anything like that. Once those cells start dying, they don't come back. Okay, so occlusions can happen via spasm, blood clot, or stenosis. Whether it's atherosclerosis or whatever it may be. Those all can happen. So, what happens in a 12 lead? Okay, what we're actually looking at. So the limb leads are composed of lead 1, lead 2, lead 3, AVF, AVR, and AVL. Okay, and all these are looking at things from a different angle. Okay, so that's the first 6 leads of your 12 lead. Okay, like I said, all these intersect and visualize. Basically, it's basically visualize the plane. You're looking from one point to the other. Okay, precordial leads, that's V1 through V6. Like I said, what they're doing is they're looking at the horizontal plane basically straight to the AV node. Okay, so you have to kind of think about it as if you're the AV node in the middle, where you're putting those precordial leads. Each one of those is basically taking a snapshot into the center of the heart from where each one of those leads are placed. Okay, we talked a little bit about the 15 lead and stuff like that. You can see how that when we move stuff over, it's basically just looking from one area to the other. So, like I said, it's a camera view from 12 different angles. Okay. We're talking about the augmented leads and those types of things. and the limb leads, we're looking more at kind of the frontal area of the heart. If you guys are looking, you got lead 1. I don't know if you can see. I'll just shut it off. There we go. So over here on the thing, you can see you got lead 1 is looking this way, lead 2, lead 3, and then the augmented leads. Remember those, AVR, AVL, and AVF. So right, left, and foot. Remember those are taking your voltage between your leads, splitting them in half, and looking in the middle. Okay. So like I said, the snapshots that we're talking about as far as the precordial leads, that's the whole thing we're talking about. It's just a horizontal view. So if you're looking kind of down here on the bottom, if you're looking, if this is the AV node, as this kind of draws down, if that's the AV on the node, we're looking basically through the middle. So if you can visualize the heart in the heart sitting in there over where those leads are positioned, okay, that gives you a pretty good idea when you're seeing those ischemic changes or infarction changes or things like that on your ECG of where that injury is actually located. Okay, and what veins or arteries, or not veins, but arteries may be involved. So there's unipolar and bipolar. So the limb leads are bipolar, okay, which means they have a negative and a positive pole. Okay, so like I said, all we're doing is really looking at electrical movement between point A and point B. Like I said, that difference is measured between the poles. So AVR, AVL, and AVF are all unipolar. Okay, so there's really no negative lead. Remember, that's what it's doing, is it's kind of taking that electrical difference between and it's splitting it in half. Okay, chest leads are unipolar also. Okay, so there's no negative pole as far as that goes. So not like the limb leads are. Okay, so we're talking about 12 lead placement, guys. Especially this is one of the things that we see quite often is people they're out there putting EKGs on. You see it in the ER. We see it in EMS. We see it in different places like that. That people are not actually taking the time to palpate the correct placement of the limb leads or the precordial leads. This is actually real important because we want to make sure that that picture that's getting taken, is actually getting taken from what we want to be looking at, in the right place. So, like I said, each positive electrode is looking at the heart. Okay. The leads are attached the 10 leads are attached for 12 lead diagnostics. Like I said, the monitor combines 2 of the leads, and that's the augmented leads. So, like I said, mnemonic for the limb leads is white on right. You guys have all heard that. White on right, smoke over fire, snow on grass. Okay, you guys have all heard those as far as that goes. So the precordial leads, like I said, this is where it gets important because, like I said, we get it too low, we're taking a nice picture of the diaphragm. Too high, we may get false readings, in areas that may not, that may not actually be involved. Okay, or we may miss that injury pattern. Okay, so correct placement of that, like I said, you're going to start off with V1. You're going to palpate down the right side of the sternum to the 4th intercostal space. Okay, you're going to place V1 there. Immediately over to the left side, you're going to place V2. Okay. Next, you're going to want to move down to the 5th intercostal space, mid-clavicular. Okay, and place V4. Okay, and then you go all the way mid-axillary or axillary here and place V6 in that same thing. And then you're just going to place V5 and V3 halfway in between those open spaces that are still left. Okay. Like I said, actually palpating, put your hands on the patient's chest is pretty important. We want to make sure that picture gets taken in the proper place. So, we got lead 1, lead 2, and AVF. Like I said, this is where you got that positive leads. Everything in here is looking down. Okay. So as far as that goes, we're not looking down, but it's looking up. So that positive lead, we're looking from the positive lead. So 2, 3, and AVF. Okay. Is when you're actually looking up at the bottom part of the heart, or that inferior section. Okay. 1 and AVL, like I said, you're over there on that arm lead, the left arm lead. Okay, so it's actually looking over here at the left side of the heart. Okay, or the lateral portion. Like I said, these are all looking at the front. So, and obviously V3 and V4 are looking straight at the anterior portion. V1 and V2 are looking at more of the septal. Okay, and 5 and 6 are looking laterally. So, kind of back up a little bit. We're going to go through and just do a little bit of a recap as far as that goes, explaining what the different waves are. Okay, because if we don't have a good idea what the waves are, it's really hard to read a 12 lead. Okay, So P wave, like I said, P wave marks the beginning of the cardiac cycle and measures the electrical impulses that causes atrial depolarization and mechanical contraction. Okay, so if we see good monomorphic rounded P waves, okay, we know that that signal is coming from somewhere, or not from somewhere, but it's coming from the SA node, and it's moving throughout the atrium with correct depolarization. Okay, QRS complex. You know, like I said, the QRS complex is measures the impulse that is caused by ventricular depolarization. Okay, remember we don't see atrial repolarization because most of the time it's always masked by the ventricles. Okay, in that QRS complex. Okay, the Q wave may or may not be seen on an ECG, and we'll talk about that here in a little bit. Okay, we start talking about some of the injuries and things like that show up. R wave is that first upward deflection following the P wave. Okay. And then the S wave is the downward deflection following the R wave. Okay, so that's basically what you're seeing there. Okay. And then finally, you know, we'll have a little refractory period there, and then we see ventricular repolarization, which is shown in that T wave. Okay. You know, we'll talk a little about T waves and things like that. You know, they should all be the same shape. You know, you guys see things like tall peak T waves could be like hyperkalemia, those types of things. So. Intervals. So P to R interval, okay, or PR. So the time, like I said, the time for that is basically that's from the electrical impulse originating the SA node and traveling through the atrium and ending up at the AV node. Okay, this should be normal. Okay, normal is 0.12 to 0.20. Okay, guys, if you got something going on there in that, like I said, that's usually the first thing you need to look at. On there, because if you got something going on there, maybe you may have some sort of AV block, or you know, something like that, especially if our PR interval is messed up. Okay. Obviously, QRS interval that we're looking at as far as that's actually the time it takes for the ventricles to depolarize. Okay. It should be less than 0.12. Anything as far as that goes, we're going to consider to be a wide complex. Okay. You know, we need to be looking things for as far as things like, you know, is it a PVC? Is this a bundle branch? You know, what's going on here, okay? QT interval, as far as that goes, is the time beginning from the depolarization, okay, to the end of repolarization, okay? So what we're really looking at as far as when we're talking about QT is that's basically from when the ventricles depolarize to they're completely repolarized, beginning of the QRS complex to the end of the T wave, okay? This should not exceed half of the length of the R to R. So if we're measuring up R and R intervals, okay, it should not be any longer than, okay, what our half the length of the R or the QT is. Sorry, QT should not be any longer than half the length of your R to R. Like I said, when we're looking at that, that's where we get some of those prolonged QT intervals that we're looking at. That could be indicative of several things. And then obviously the ST segment, okay, we're looking basically at the end of the S to the beginning of the T, okay. You know, some of the things, especially when we're going to talk about STEMI, you know, about ST segment elevation and things like that, we're looking for that J point to be around that isometric line. So starting off here, as far as this goes, like I said, this is going to be a normal sinus rhythm. Going through here, you got a nice rounded P wave as we're going. You can see a little bit of deflection. Like I said, this may or may not be on every ECG, but you'll see this Q wave as it goes down here and deflects. R wave's going up. This is ventricular depolarization, R and S, and then your ST segment. Okay, so that's basically between the S and the T. Okay, one of the things we're looking at, like I said, the little section that's right here is going to be your J point. Okay, that's where your S interval turns back to your into your ST segment. So that J point is where we're looking at for that when we're diagnosing, like I said, ST segment elevation or depression. We want it to be, you know, it should be right around that isometric line. Okay. So, like I said, some of the things that we may see, okay, when we're looking at ischemia. Okay, so guys, remember, what is ischemia? So ischemia is one of those, you know, those things that we're looking at. You know, what's ischemic tissue? You know, it's hypoxic. It's with a lot of oxygen. You know, maybe this is a new blockage, a partial blockage. Just remember, the ischemia is anything where the workload of that tissue is exceeding the amount of oxygen and, you know, glucose stores and things, that the energy that it can be produced by this materials it has. Okay, so that tissue is going to start to become ischemic. Okay, so some of the things that we look as far as that goes, one of the earlier signs before we start seeing all these, big tombstone STEMI more or less, okay, before we start seeing this big elevation, we may see these things starting to show up on ECGs prior to seeing those big tombstones, okay. One of the first signs as far as that goes is going to be like an inverted T wave, okay. So basically that's exactly what it is. Instead of our T waves coming up and being upright, they're just going down, okay. They may be even depressed, like we call it the T wave flattening, so they may just be depressed or even smaller, okay. So these are normal. See, those are flipped upside down, and then you see that those over there, they're not very tall, okay. Maybe even a little ST depression on that, okay. So like I said, that's that kind of that depressed looking. You can see right here the isometric line should be running right across the bottom here, and you can see that J point on each one of these is below that isometric line, okay. So those are some of the things that we may want to look at, especially when we're looking at each one of those leads, just to kind of be looking at the morphology of that complex, okay? Because that may give us some indications that, hey, this patient's having chest pain, this is what's going on. I don't see an obvious STEMI on their EKG, but if I can see, a few of these things that we're picking up, and we see this, across the board, and in several different leads, we may notice that there's an area there too that may be starting to get ischemic, okay? So obviously injury, these are all the things that, we go, oh my gosh, we're looking at the EKG, this is kind of a poo-haw moment, we need to get them to the hospital, okay? Pretty obvious, right? If you guys are looking down here at these things, we can see that, right here on this first one, that's going to be an MI. There's a few things that cause that. We'll talk about pericarditis and things like that. But what is ST segment elevation, okay? It has to be at least one or greater than 1 millimeter in at least 2 continuous leads, okay? We'll get to some 12 leads here in a second that we're actually looking at, and we can see some STEMI patterns and things like that. A lot of times if you're thinking about where those leads are at, and you just think about if there's an injury in a certain area, you would expect that there would be a lot of ST segment elevation where that injury is really bad, okay, or maybe that infarction's happening, that injury, and then you would expect that it would be starting to get less and less and less. You can kind of think of it like a burn or something, So that's why you may see that the elevation, kind of coming up. Especially, it's real common on the, anterior and lateral MIs, where you'll see maybe 1 millimeter of elevation in V2, V3, and then it starts getting bigger, V3, V4, and then V5 is real big. V6 starts going down, things like that. Like I said, it's real common, so looking for that. So like I said, we have to have those 2 continuous leads, okay? You may see heightened or peak T waves with some of that, but basically this is directly related to portions of the myocardium rendered electrically inactive, okay? So like I said, that stuff's not working. That muscle, that tissue's not depolarizing. Remember, like I said, electricity travels different through hurt tissue than it does through healthy tissue. So infarction, as far as that goes. So when we're looking at that, like I said, when we're talking about infarction, all those other things, we start to see the really pronounced significant Q wave. Okay, you're seeing over there in the deal. Like I said, the Q wave really starts to be evident in some people, and then it really starts to dip down also. Okay, so like I said, especially if there was none where we didn't have one previously existing. So like I said, the impulse is traveling away from the pelvis sleeve. Necrotic tissue is pretty much dead at that point. Like I said, there may be no Q wave in subendocardial infarcts, okay, because it's like I said, it's not a fully, like I said, the thickness of the tissue has not fully been dead, okay, but you will see those depressions and things like that, okay. And this is often, like I said, often we see that right there is often a precursor of a full thickness MI, okay. Like I said, such as that, like I said, an infarction may be on the inside, it just hasn't got all the way through on the outside, but we're seeing it, okay. So criteria, though, like I said, the depth of the Q wave should be at least 25% the height of the R wave. Okay, we're actually looking for straight-on infarction. Okay, width of the Q wave, like I said, is usually about 0.04 seconds, and we start seeing the R wave starting to diminish. So if you're looking over there on the top, you see it's starting to get a little. Like I said, that's definitely a quarter, at least a quarter of what that R wave is. Okay, and R wave is becoming a little depressed or shortened. So like I said, this is kind of the stuff that we're looking at, okay? So if we're looking at different things that we're going through as far as the, evolving of an MI and what's happening. we're looking at right here, this is pre-admission. Maybe, hey, we go out there and, they're doing all sorts of stuff. Everything looks great. Hey, their EKG's good. Bam, and all of a sudden having chest pain. We hook them up on EKG. Bam. Okay. They got big tombstones. We got ST segment elevation. Okay. Within an hour, it starts, like I said, this is, you have to kind of think about that tissue is getting more and more and more unhealthy. Okay. Cells are dying. Okay. Like I said, you can see pretty healthy heart up here prior to that. And then as these things start going on, you can see the depolarization and repolarization in that in those cells is greatly affected. Okay. So how do we take a part of 12 lead? How do we read it? How do we look at those types of deals? It's like these are basically horizontal marks in time. So you have to think about it. The first section you're seeing is lead 1, 2, and 3. Then you got AVF, AVR, and AVL. V1, V2, V3, 4, 5, and 6. Okay, so each one of those sections that you're looking at in a 12 lead is 3 seconds in time. Okay, so you got the first 3 seconds it's looking at, second. So you got a total of 12 seconds for that EKG to be taken. Okay, vertical marks or amplitudes. That's what you're looking at when you're looking from voltage going from one place to another. 6 leads, 6 precordial leads. Okay. Positioning measures 12 perspective reviews, and that's exactly what we were talking about with positioning. Is we can move each one of those leads around at different places to look in different views. Okay, we just have to remember which one we move where. Okay, so like I said, limb leads we've already listed all those. Precordial leads we listed those V1 through V6. Okay, so normal EKG that we're looking at, if we got one that's put up here. Okay. Like I said, these are all going to be your precordial leads that are over here. These are all, limb leads. And these are all your precordial leads on this side. So like I said, each one of these sections, bam, that's the first 3 seconds, second 3 seconds, third, fourth. Okay. As far as that goes. So like I said, each one of those are in there. So we're going to put a couple of little color blocks up on here. See a few things that are going to pop up here. Okay. We're just going to start talking about trying to color code some of this stuff. Okay. So an anterior MI. Okay, that's what we're going to back up here as far as that goes. You got some yellow things we'll talk about here in a second. But this indicates an anterior MI you're going to see in V1, V2, V3, and V4. Okay. Basically, this is anterior infarction with ST segment elevation. Usually involves that LAD, the left anterior descending artery. Okay. V1 and V2 may also indicate septal involvement, which basically extends from the front to the back of the heart along that septum. So basically just that top corner there. Okay. Could be a left bundle branch. Like I said, we'll see left bundle branches blocks in there. We'll see right bundle branch blocks in those leads. Secondary heart block, complete heart blocks. Okay. All can happen from basically the occlusion of that artery. Okay, and that's going to be over here on this side. So basically, if we're seeing those things that we're talking about, that ST segment elevation, depression, you can obviously see right here on this lead. And that was kind of what I was talking about earlier. Especially those anterior, you see there's a little bit of elevation here on this one, a lot more, a lot more, a lot more, and then it starts going down. So we can kind of see as it's kind of building up and going down. So I would say the majority of that injury, okay, is going to be right in this area, V2, V3, and V4 area. Okay, it's probably where the center of that occlusion's at. You guys, this actually tells the cardiologist a lot about when they're looking about that, about when they go in there, they're just not sticking that catheter up there in the cath lab just in any old place. They're actually going to look at that EKG and go, yeah, that's probably the LAD, it's probably halfway down there. If that's wrong, to go in there and attack first and see if we can find the blockage. Okay. So like I said, that yellow section right there, that's an anterior MI. Okay, so like I said, all we're really doing is trying to figure out what the different injury patterns are and how to identify them. Okay. Inferior MI, you guys all know this. Okay, 2, 3, and AVF. Okay, we got reciprocal changes in lead 1 and AVL, right? So inferior, like I said, and this is what we're going to blue. That's 2, 3, and AVF. And this is with ST segment elevations. Then it's usually the right coronary artery, guys. Like I said, we can see first degree block, second degree, both types of second degree, third degree. Nausea and vomiting is pretty common as far as this goes. Because like I said, it's that bottom portion of the heart. That inferior portion, it's just right on top of the diaphragm. So we get a lot of referred pain, nausea, vomiting, those types of things. I want to say probably a good majority, and you guys can probably attest to well, probably a good majority of the females, or especially elderly females that you see out there, probably if they're having a STEMI, they're having this type of one. You know, we do see a lot of inferior MIs. So like I said, these are those two over here, 2, 3, and AVF. You know, we'll talk about reciprocal changes here after a little bit. You know, see, like I said, you should expect to see some depressions in AVL and lead 1. Okay, like I said, we're really looking for that elevation. Okay, and 2 more consecutive leads. Okay, some of these things that we're looking at. Okay, you were talking about 15 leads as far as that goes. How many of you guys have ever done one? If you can throw a comment on there, just say yes, I have, or whatever else it may be. How many of you have ever done a right-sided EKG or a 15 lead EKG? Okay. Why do you guys think that we may, especially looking at this EKG, why would there be some reason that we may want to do a 15 lead? Especially if we look over here, I'm going to kind of scooch across the screen here. If we're looking over here to this side in V5 and V6, you can see that there is a little bit of elevation over here as far as that goes, and that's looking right here on the lateral side of the heart. Okay, did I screw the camera angle? Am I moving? Okay,
you're fine.
So let's look around that lateral side of the heart. So maybe something we may have some posterior involvement with that also. You may be coming around the bottom side of the heart and into the back. We may also have some right-sided involvement. So easy way to do that, is like we're talking about, is like I said, at least doing a right-sided EKG. We have to rule out right ventricular involvement, especially before we even try to medicate this. Guys, we need to see, a lot of times that's just as simple as moving V4 over to basically opposite the side of V3, that becomes V4R. Taking your 12 lead again and looking at that, because we want to see if we see ST segment elevation in those leads. We have to rule out right-sided involvement just for the sure fact that we go to give them, nitroglycerin or something that's going to vasodilate them. Their preload may already be vastly affected by that MI. If we go in and we take all their preload away by vasodilating with some sublingual nitro, we very well could send them into cardiac arrest. Okay, at least drop their pressure dangerously. Okay. So like I said, kind of think about that as far as it goes. As we're kind of commenting along here, doing things. Like I said, you've got some cases out there that are clearly inferior MIs. Those are kind of the rule of thumb I go by. Is if I pop an EKG on a patient, it's showing an inferior MI. I always want to rule out right-sided involvement or posterior involvement prior to giving them any sublingual nitro. Okay, just because, like I said, have you guys ever seen that? Ever heard? Like I said, do you guys practice that too? It's just a good practice. Okay. So there's something back there, but taking a dextrocardia whenever I see something, let's just do it inferior leads. Okay. So and that's basically just doing the EKG on the other side of the deal. Like I said, it's going to be more accurate in ruling out right-sided involvement. Kind of like I said, you can't do a complete right-sided 12 lead. And it's basically just moving everything, with the exception of V1 and V2, the same places on the right side that you would do the left side. Okay. Like I said, this is really going to help the cardiologist out as far as that goes. Like I said, you're just mainly looking for ST segment elevation in these two leads, really. Okay. To rule out right-sided involvement. So here's the thing, guys, right there. Right-sided involvement occurs about 40% of all inferior MIs. Okay. I don't know about you, that's a big enough number for me to be like, I really want to check this before I start dumping nitro on it. Okay. Like I said, as far as it goes, it's a larger area that can be infarcted. A lot of times in this, like I said, it's going to involve both ventricles. And what would we do as far as a treatment? It's going to differentiate our treatment. Like I said, that sublingual nitro is now gone out the window. Okay, we may need to consider something like nitro paste. Something that's a lower dose and we can take off as we need to. Okay, we can add more if we need to. You have the capabilities of doing a nitroglycerin drip. Those are really awesome because you can turn it up and turn it down. Okay, works to kind of go with that. So, like I said, those right leads will look directly at the right ventricle and show you ST elevations. Like I said, it's usually going to show in 2, 3 AVF. Okay, that you would already expect to see that. and then that V4, V5, and V6. Okay, and it'll be just kind of like what we showed you on the anterior MI, where you may see those injury patterns starting to climb and fall. Okay, over that area of infarction. So an occlusion of the right coronary artery in proximal is enough to basically involve that right ventricle. Okay. So what do we see that maybe, like I said, some of the other signs and symptoms that we may see of right ventricle involvement is that hypotension. Okay, like I said, because they don't have much preload, or like I said, they don't have much of that atrial kick. Okay. On that right side to be able to get that right ventricle filled up. There's not much preload coming into that. So this patient's already maybe to that kind of hypotensive stage, you know, especially if you do give them nitro. We may see JVD too also, because remember that blood's kind of backing up because that right ventricle is not working correctly. And these patients will have dry lung sounds, okay? So like I said, this right here, you see a little thing pops up there, there is the right ventricle. Okay, so we'll kind of move away from that. We'll hit over here and talk about lateral ECGs or lateral MIs, and this is basically this red section that we're on right here, and that's basically going to be lead 1, AVL 5, and 6. Okay, and that's what we're looking. Like I said, remember some of these guys are reciprocal changes. Okay, lateral infarct, basically this is ST segment elevations, and this is usually that left circumflex, guys. So this is where it's coming off. Right here, that left anterior descending, okay? Right here, coming off of that and going around the left side of the heart, okay? So that left circumflex is what's being involved like that. Like I said, the issue with this is it's rarely involved by itself, okay? You got to kind of think about it. If I'm a clot and I'm floating down through there, I'm usually going to take the path of least resistance, okay? So I'm either going to get stuck up here, or most of the time, if I do, it's going to be somewhere in here. So it's usually if that gets blocked, it's going to be someplace up in here. It's less likely to make that turn and get a blockage down there. Not that it can't happen, but it usually involves the left anterior descending and that left circumflex together. Okay. So like I said, lateral MI, you're looking for those big elevations. Of course, they're going to be over V5 and V6. You may see some in AVL and lead 1 also. Okay, just because of the way we're looking across that heart. If you remember back there on the limb leads, the way that looks across and what portion of the heart it's looking at. Okay, posterior MI. Okay, like I said, this is obviously the back. We've got the heart flipped around here. This is the back side of the left ventricle. You know, we want to, like I said, this is going to be like V1 and V2. So what you may actually see in V1 and V2 is you may see ST segment depressions. Okay, but you got to kind of think of it as elevation and depression. What you're looking at is basically if I'm looking at, if you guys are, like I said, if I'm the heart and you guys are looking at me, straight here in the middle, you see ST segment elevation. If I turned around from the back side and you look this way, you should expect to see depression. Okay, and that's vice versa. So when we flip our leads back around, you know, if we move our leads back around here in a second and look at the back side of the heart to get that posterior, we would expect now to see what we were seeing in V1 and V2, that depression. Okay, and so V8 and V9, we're now going to should expect to see elevation. Okay, and that's going to confirm that we do have a posterior MI. Okay. Like I said, we'll probably see that the ST depression in V1 and V2, especially with a tall R wave. Okay, this is usually the right coronary artery or the left circumflex. Okay, like I said, understanding those reciprocal changes is pretty important. Okay, so that back of the heart is viewed as, like I said, as a mirror image. That's what exactly we just talked about. Okay. Elevations versus depression. So if you see those depressions in there, you know, don't kind of overlook that or blow that off as going, oh, I've just got depression here. Okay, that you may actually be seeing elevation just in reverse. Okay, so you may have a posterior MI on your hands. Okay, so kind of think about this, and like I said, usually if this involves some part of the right coronary artery and the left circumflex. Okay, now we may have some right side stuff going on, part of the left, you know, maybe the front, maybe the back of the left ventricle, and things like that. So these people could be really the pump's really not working very well. All right, so looking at posterior, like I said right there, you're looking at V1 and V2, you see those ST segment depressions, okay? Usually, like I said, when you see something like that, and like I said, this is going to be actually a pretty big one because you're actually seeing it into V4, V3, and V4. You do see some elevation over here to lead 1 and AVL, so this has probably got part of the posterior and part of that lateral, or that lateral side. You know, we're talking about this back or anterior. We're talking about that back there before, so you can see some of the elevation changes there. So like I said, with doing the look at the posterior leads, like I said, all you're doing is you're taking lead 5 and lead 6 off. You're moving them back around, same in the intercostal space, and you're just putting them right here on the back. Okay. 5th intercostal space, V6 is going right here, basically just mirrored on the back from where your midclavicular line is. Okay. In the 5th intercostal space, and then V5 goes right next to it. Okay. Just kind of mirrored just like it would be on the front side. Okay. And that's going to give you that view from the back side. Okay. All right. So subendocardial, like I said, these are the things where basically that infarction has happened. It usually occurs more deep down inside the veins in the the arteries in the smaller endings of them, because it's got to kind of flow into that stuff. So like I said, subendocardial is basically inside the more towards the interior of the heart. Okay. Like I said, what we're doing as far as subendocardial, and that one, that's probably really hard to see on the screen. So basically, there's really no color code for those that I've got up here, just because you can't really. We're looking for the changes that we see. We're looking for those localized changes in the different areas and those Q wave abnormalities, the T wave inversions, ST segment, the depressions, when we don't have that reciprocal change. Does that make sense? If I see some depressions in some areas, I turn around and look at the back side of the heart, or look at the right side of the heart, but I don't see that elevation that's matching it, we may think that may be a subendocardial infarction. Okay, so looking at here, like I said, you're not seeing anything on here that's just greatly tubestone in, but I do see some depressions. Okay, there's some in V2, V3, 4, and 5. Okay, so at least, like I said, those are at least 1 millimeter. I forgot circle on V3. All right, so you guys have any questions on that? I know we kind of ran through that pretty quick. Any questions so far? Okay.
No, there hasn't been any so far. I had several responses to the 15 lead question.
15 lead question, okay. Like I said, any questions on that so far? Just how to kind of pick them up. I'm trying to break it down as simple as we can. It's literally just you're literally just looking at like 4 or 5 different areas of the heart. And look at as far as that goes. So like I said, when we start to combine these together, guys, it's going to be pretty rare. Most of the time when you see a STEMI or you have something that's going on and you have that ST segment elevation, it's pretty rare that it actually occurs in just one of those injury patterns. Okay, so when we have to kind of start combining these together, okay, so like I said, you may have it what we call an anterior-lateral, okay, or inferior-posterior, or inferior-posterior, or anterior-septal, okay. So those are all those kind of areas, like I said, we're just combining those 2 injury patterns together, okay, that we're looking for, okay. So this kind of just shows the chart up here as far as that goes, what actually, when we're looking at it, what leads are actually involved, okay. We've got them all kind of color-coded out here. So anterior wall is going to be V4, V3. That we're looking at septal is V1, V2. Inferior right here is blue, 2, 3, and AVF. The red's really hard to see, but it's over here on the lateral side. Okay, and then lateral is going to be 5, 6, 1, and AVL. Okay, it just helps kind of put a little bit of picture on it, a little visual aspect of it. So I'm just sitting here throwing all these numbers. Okay. So let's talk a little bit real quick as far as this goes. I've got a bunch of these up here. We're not going to sit here and go through all these. We're going to kind of practice here with a few of these 12 leads. So Jeff, can you zoom in on them as far as that goes on the screen?
Yep. Stand by.
We'll get it zoomed in here. That way you guys can probably see these a little bit better. I apologize, they're not the greatest copied strips. And then we'll just kind of talk about them here a little bit. So,
zoom in. Just give me a moment.
We'll kind of slow down here a little bit, guys. If you guys are already looking at this and you're seeing, go ahead and comment on there. What do you think this is? You think this is what type of MI this is? Okay, and we'll pull it up here. Well, like I said, we'll hit each one of these a little bit and kind of go through it.
Okay.
Okay. Good. So what do you guys see the most when you're looking at there? I mean, what just kind of jumps out and goes, oh my gosh. Okay. We got some pretty major ST segment elevation in V2, V3, V4, a little bit in V5. Like I said, it kind of goes down. So we at least have what type of MI. Okay, at least if we're just looking at that point. You know, that's usually where I go, especially when I look for ST segment elevation depression. I look at the biggest oh my gosh point. Okay, and that's where we're that's probably where the biggest portion of the blockage is. Okay. So we've got, like I said, we have some sort of probably just a little bit of anterior involvement there. We're looking over here in the inferior leads. What do I see in my inferior leads? I've got some ST segment depression, right, with elevation in the reciprocal channels areas. So that may tell me that I may have some posterior involvement, possibly, okay, or lateral. Okay, so it just depends on what we're looking at. Like I said, that posterior side, that lateral side, depending on how much we're seeing. Okay, so this, like I said, is an anterior MI with lateral involvement. We see the elevations, okay, in 2, 3, and 4. Okay, we also see that's actually supposed to say depression. Okay, with ST depressions in 2 AVL and V5. Okay, what do you guys think about this second one? Kind of pause here for a little bit, let you guys kind of look it over and see if anything's jumping out of you. These are pretty easy. I just now noticed that this strip says 2, 3, and it says V1, V2, V3, V1, V2, V3. So we're not sure what's wrong with the printer on that one.
I don't know what you're talking about.
But I'm sure that's supposed to say V4, V5, and V6. Okay. All right. So we definitely have ST segment elevation in which areas? Okay. Definitely, for the most part, the biggest stuff we see is that V2, V3. Okay. A little in V1 and V4. Okay. Do we see any any major changes anywhere else? Okay. Any elevations, depressions, inverted T waves, things like that? Okay. Anterior septal, because like I said, we see that basically all our elevations are in 2, 3, and AV, or like I said, lead 1, 2, or V1, V2, V3, and V4. Okay, so we got the front, and obviously the top portion of the heart there. Okay, pretty common one that we see. All right, what do you guys think about this one? We should see a lot of hands going up or a lot of comments going on this one. This is a pretty common one. See our major elevations. Okay, we have a bunch of elevation in lead 2, lead 3, and AVF. We have some depression or reciprocal changes in AVL and lead 1. Okay. We also have some minor elevation over in V5. Okay. Like I said, that's basically case in point, straight up inferior MI. Okay. 2, 3, and AVF. We got some big elevations. All right, move on here to number 4. Okay. Looking at this is kind of, man, it's all over the place. Okay, so how do we decipher this? What are we looking at? Okay. Like I said, start off with the places you see the elevation. Okay. Which one looks bigger? Which one looks, oh my gosh? Okay. Probably looking over here on the inferior portion of it. Okay, we got quite a bit of elevation in lead 3, quite a bit in lead 2, and quite a bit in AVF. Okay, we also have some elevation over in V4, V5, and V6, with some depression. You guys notice that? Depression in V1 and V2. Okay, so this EKG right here may have some. It's definitely, we have some inferior involvement. Okay, you guys remember what the depression means in V1 and V2? We also could have some posterior involvement. And we probably have a little bit of, maybe a little bit of anterior and or more likely lateral. So this is probably lateral extending to the posterior part of the heart with inferior. So we're probably going to call this one an inferior lateral MI. Okay. I said this is definitely, I would definitely want to take this and, like I said, definitely get around the back side of the heart and do that 15 lead. Look at V8 and V9. Okay. So this one's actually really easy to read. Okay. You guys can see that one on there. So what are we looking at here? These are on there. Anything that's just jumping out going, we got ST segment elevation, ST segment depression. Okay, not huge elevations, but we do see some depressions in some places, right? Okay, we got some pretty good depression. We do have some elevation of V3, sorry. Okay, V3 AVF. Let's look at that wrong. Okay, so 2, 3 AVF. We do have some depression in lead 1 and AVL. Okay, we also see a little bit of depression in lead 2 or V2. Okay.
You got a looks bad, drive fast.
Yeah, looks bad, drive fast, right? Okay, so this is basically an acute inferior MI. We're not seeing that stuff. Like I said, those areas we're seeing, we don't see those big tombstones, right? Okay, this is something you guys remember. We went back to that kind of a pre-admission area and then that admission part. You know, everything looked fine until it wasn't, right? Like I said, with any patient that's having chest pain or you suspect or you see that elevation, we should be taking those recurrent EKGs. You know, on the way to the hospital, you want to see if something's getting better or something's getting worse. You know, so taking those multiple EKGs. Like I said, this one definitely be one of those people that, you know, hey, that's got some inferior involvement. You know, there may be a little bit of posterior or right side over there that we're looking at, but I would definitely want to check that out before we give them anything. And definitely taking, you know, doing a couple EKGs on the way. You know, I'd expect that one to get a lot worse. Okay. I've got some additional practice strips that we'll kind of go through. Like I said, this is going to be up there if you guys want to look at it. You know, it should be on there on the deal if you guys want to go on and look. You can at least look through these. I'm just going to kind of go a little bit slower here through them so that way you guys can at least pause the video and just kind of look at it and just kind of practice kind of diagnosing some of these. Okay. Like I said, I threw some up there because they're not so clear. They're not so easy to read. It's not a textbook evident strips that we see. And like I said, none of our monitors show those perfect textbook looking runs either. So pretty good practice ones. We'll get through a few of these here, and then I've got a few more things we're going to talk about with enzymes and stuff. Okay, so when we're looking, like I said, we don't have iStats unless you're on the helicopter. They got iStats there, but checking cardiac enzymes. Guys, enzymes are these things, like I said, that are you know, that's how they diagnose a non-STEMI. You know, if basically their EKG looks normal, but they have cardiac enzymes, they call it a non-STEMI. You know, but we're looking as far as the normals. So CK or CPK, like I said, is going to be 10 to 155 per liter. This, like I said, begins to rise 3 to 6 hours and peaks within 12 to 24. Okay, with a return to normal within 3 to 5 days. Okay, and these are enzymes we're looking for after injury. Okay, so CPK in B is usually less than 5%. Okay. LDH is, like I said, is usually going to be 85 to 200. This is going to begin to rise 12. We're going to rise in 12 hours. It peaks at 36 to 72, and it takes about 10 days to get back to normal. Okay. There's the factors for LDH right down there at the bottom. Okay. Troponin, here's the things that you guys see. Troponin's the gold standard. Okay. You're only going to get that from one place. You guys know what that is. That's going to be cardiac enzymes. Okay. Infarcted or infarcted tissue. Like I said, this starts to rise 3 to 6 hours afterwards. So if you, like I said, we're backing up on here. There's a few there, but like I said, that's pretty. You know, troponin is pretty kind of the gold standard, pretty as far as it goes. So negative troponin within 6 hours of onset, like I said, that rules out. The onset of sinus symptom rules out an MI. You know, especially these patients that are going there with chest pain, those types of deals where they're not really sure as far as the EKG. They do an initial troponin. You know, if it's still negative within 6 hours, they weren't having it. You know, they weren't having an MI. Okay. It peaks at about 20 hours. Okay, and it's like I said, troponin may be raised for 14 days. Okay. Afterward, maybe some patients even longer. You know, we see some patients that sometimes have such a bad infarction and things like that. We see some cardiac enzymes for quite some time after. So troponin T, like I said, this is 84% sensitivity for an MI after 8 hours onset of symptoms. Okay, so it's pretty accurate. Okay, if we got you know at 88%. Okay, for MIs being able to tell us that. Okay, 22% is for based on interstitial angina. Okay, so not that big of high. Like I said, the advantage of this is highly sensitive for detecting myocardial ischemia. Okay, only comes from ischemic tissue. Like I said, the levels may help to stratify the risk. Data specialism as far as troponin T is it's less specific than troponin 1. Okay, it is increased the angina versus as far as the ischemia. Okay, and troponin T is also increased with renal failure. Okay, so you could see some of that type of stuff. Troponin 1, like I said, as far as this goes, is a little higher. It's 90% sensitivity for MI after 8 hours with an onset of signs and symptoms, and 95% specificity. Okay, a level of greater than 1.2 suggests an MI. Okay, when we're looking at that as far as troponin 1. Negative, like I said, a negative as far as no troponin 1 there pretty much rules out an MI. Okay, you obtain 2 negative, like I said, negative troponins within 4 hours. Like I said, 4 to 6 hours apart. Like I said, we're 100% sure they won't have any infarction. Okay, especially those people. Like I said, we were talking about the non-STEMIs. That's really the only way to be able to tell. Like I said, normal is exceedingly low. Okay, so even a small elevation indicates myocardial damage. Okay, let me go on there. Okay, so guys, there's just some of the references where I got some of the information on there. If you guys have any questions, like I said, it's just a quick, brief overview as far as it goes. You guys got any questions, comment on here. I'll be here for a few minutes. As far as it goes, be able to answer whatever you guys think, and we can be able to go over this again if you guys need us to in the future. So, all right, any questions so far?
That's been any questions. There's been several prayers, and they're going to the
Prayers
cath lab and stuff like that.
I'm going to the cath lab.
Not you specifically, not you personally. Well, I don't know. Maybe they've been.
I was like, maybe. This is getting hot in here.
It's warm.
So
Take the
the heat kicked on, yeah.
Got bumped back up. All right, everybody. That's probably all we're going to stream for today. I've got some content I need to upload, and I can't stream and upload at the same time. So I think we're streaming for today is finished. Thank you very much for tuning in and all your comments. I appreciate it. Don't log out or sign out anywhere just yet. I will send some information out, and I'll get some information and some other presentations uploaded that we recorded last week and then this morning, and then we'll be done for today. Thank you.
Thank you, guys.
See ya.